Welcome to this morning's discussion on the Susie. Where would we like to start?
George, I think his name is, like, avoiding his girlfriend, I guess, and like not wanting. He knew like she was probably gonna break up with him and just avoided her instead of confronting her.
All right. Any observations? What might be going on? I mean, other than the obvious.
For the ball.
Huh?
For the ball.
What's that about? And I think there's two things that come to mind, and ironically, I can't say they're complete opposites, but they're kind of on opposite sides of the pole. One, if you just look at the behavior itself, the first thing that comes to mind is avoidance, right? Now, it's not going to be avoidance the way we usually see it appear or present in clinical practice. But nonetheless, it gives us a door to kind of investigate that, to discuss that, especially for purposes of the shelf exam. I think one of the first things that I want everybody to consider is that, unfortunately, avoidance is a initial manifestation of multiple conditions, especially within the anxiety disorder spectrum. And to kind of parse this out, we look at the anxiety disorders and then remind ourselves that these conditions were reorganized back in 2013 with the latest revision of the DSM. And wherein we had all of them listed in a single chapter, in the DSM-5, we have 3 separate chapters now, including the anxiety disorders, keeping the original title. But then 2 additional chapters, the obsessive compulsive and related disorders, as well as the trauma and stressor related disorders. So now there's 3 chapters. And certainly from the anxiety disorders and the newer chapter, trauma and stressor related, we have multiple conditions that can present with avoidance behavior. Now, in clinical practice, as a clinical pearl, it is unlikely someone is going to present to you with a chief complaint of, "Hey doc, I'm avoiding." It's usually the consequences of the avoidance behavior, including depression, and especially anxiety, and likely both, for which the individual is seeking help. Right? So that's number one. It's probably a good idea at this point, if we're going to stick, and now we'll name all 3 or look at all 3 of those chapters. What are some of these conditions, and how do we begin to differentiate one from the other? I.e., what should you look for? What details should you look for in your case vignette on your shelf that allow you to choose one as a single best answer? So let's name the conditions, and then let's try to find a differentiating characteristic or trait within these 3 chapters of the DSM.
Generalized anxiety.
So generalized anxiety disorder. Right now, I would put this lower on the list in terms of a differential, but certainly it's going to be included in our list. What is the one aspect of generalized anxiety disorder that we could kind of grab onto to, if there's one pearl to remember for test-taking purposes at least?
Is it excessive worrying?
Yeah, it's the excessive worrying, right? The other thing I want people to remember, and this is more of a clinical pearl, is that generalized anxiety disorder has specific DSM criteria. And I really want you to use the word general and specific in the same sentence, because it reminds you how much of a misnomer this condition is. And because of the mistitle, because of the mislabeling, many people believe that this condition is a grab bag category. That is, if I have a patient with clinically significant anxiety for which I can't figure out what's going on, it's not OCD, it's not PTSD, it's not acute stress, therefore it must be generalized anxiety. Unfortunately, a lot of people who are labeled or diagnosed with this condition are diagnosed as a default, and this is absolutely wrong, right? If you look at the DSM criteria, the specific DSM criteria for generalized anxiety disorder, you basically have a combination of both anxiety, especially worry. That's exactly what you need to look for. And then signs of depression, right? So anytime somebody who looks depressed is also has that persistent worry, please think of generalized anxiety disorder. All right.
Cramming?
Hmm?
Cramming. Kramer?
And I need more illnesses. I'm not going to let you go with just one. I want at least 4 in this list.
PTSD?
But yeah, definitely. And I'm going to include acute stress disorder here too. So, all intents and purposes, it's the same thing. Time course will differentiate one from the other. Avoidance is a big criteria here, right? And in fact, they have an avoidance criteria set that you have to actually review, right? And that holds true for acute stress disorder as well. 30 days, right? 30 days. Up to 30 days, we're going to call it acute stress, and a month or more, we're going to call it post-traumatic stress disorder. 2 more.
Obsessive compulsive disorder?
Very common. Yep. I would put this one around the space that I would list generalized anxiety as well. Yeah. And we talked about OCD as recently as last week. I still want 2 more. That's how many there are. I'm going to offer them. Agoraphobia and social anxiety disorder. Okay? Both can, again, present with avoidance behavior. Having said that, what differentiates one from the other? This comes up in exams a lot.
Agoraphobia and social anxiety. Social anxiety is more of a fear of being judged.
Go on.
And agoraphobia is like the fear. It's not really that they're afraid of going outside, but what might happen when they go outside, not like the direct judgment of other people, which is social anxiety.
All right? Everybody get that? The bottom line here, whether it's in psychotherapy or whether it's on a test, you have to discover what the fear is. Right? The individual with social anxiety disorder, the fear is the social or the performance situation in and of itself and what that invokes. Whereas agoraphobia, it's the fear of becoming symptomatic and therefore being embarrassed. Right? So be very careful in terms of focusing on what the fear is and therefore allowing you to determine the single best answer or the most likely diagnosis. Right? For social anxiety disorder and looking at, actually, take it back. For social anxiety disorder, the performance or social situation itself, what is one of the most common examples? And the hint here is that in 2013, the APA identified this as so common that we have core specifier here.
Is it public speaking?
Yeah. We actually have a specifier for that. It's so common, right? Be careful. If I were to write a test question, wink, wink, all right, on your shelf, if there is someone who is fearful of going to the podium, a professor, and because of that, their job is at jeopardy. So they're going to come to you because that's clinically significant to them, right? It's causing clinically significant distress. You might be very quick to look at that as social anxiety disorder, but if they offer you that the fear is because that East Lecture Hall, that one door is always closed, and if they became symptomatic, they couldn't escape in time, having to run up those stairs, right? That's agoraphobia. Right, so be very, very careful. Read the questions very, very carefully. All right, other characters, Psyfeld. Kramer, what's going on with Kramer in this episode?
I think he's pushing himself into everyone else's lives too much, like gambling for Jerry or like breaking up with George.
Mm-hmm.
Breaking up with George from his girlfriend's side. He's just he doesn't have his own life. He's pushing himself into everyone else.
Did you get that?
And it's so weird.
Kramer, definitely an unusual character, and we see this pervasively with him. What else do you think is going on here?
He's got like bipolar or something because he's something like ADHD maybe.
Thoughts? I never really appreciated whether Kramer was truly manic. Certainly we could discuss that.
I guess I'm picking up on the manic tendencies. I'm not sure what I would diagnose that as, but it seems like more he like wants to appease people and feel included. I don't know what that would be though.
Mm-hmm.
I was thinking like fear of abandonment, like maybe something like PTSD from like his parents or something. And so like because he's so scared and like has anxiety possibly from what happened, he pushes himself onto people because he doesn't like want to be forgotten.
Yeah, there might be something there. I mean, not this episode. I think it might be the stall. I'm just grasping here. We actually meet his mother, and there's clear abandonment issues there when Babs comes back into his life. And he actually has a line that says that he had to overcome a lot. Paraphrasing. So there might be something there with that. The other thing about Kramer is that he always strikes me as a cluster A. He's odd and eccentric, and he doesn't pick up on social clues or cues. And that might be a big part as to why he oversteps and there's these boundary violations. And in this particular episode, and we'll swing this back to George now because George is so fun to talk about, with regard to what Kramer does, there's another reason why George might be avoiding, which is the direct opposite of the reasons we just discussed. Right? So he's avoiding talking to his girlfriend or soon-to-be ex-girlfriend, largely because he wants her to be at that ball. Right? But the focus really of this episode is on that ball. And of all things, it has everything to do with stuff that is other than avoidance. That is, he wants to be the center of attention. Right? He wants her to do the twirl when she enters. Right? What's that about? So we have a whole set of illnesses: agoraphobia versus, we didn't mention panic disorder versus OCD, generalized anxiety. I mean, there's a spectrum here to consider, but there's also another illness to consider here too, where, and really the antithesis would be that he wants to be and needs to be the center of attention.
Like narcissism?
Yeah, it's histrionic personality, right? The individual who either verbally or non-verbally, this grand entrance, makes sure that the attention, the spotlight is drawn to them. He intends to have her by his side when she makes that grand entrance with a backless dress and spins into this ball. So that's something to consider here too. Yeah. Other characters, final thoughts. Psyfeld.
The whole Susie thing.
What about it?
I don't know why she didn't say it. I mean, I guess it was for like the show purposes and to be funny, but she created this whole like elaborate lie with like the funeral and everything, which I think was a little extreme for real people purposes.
What else is going on here? Remember, when we try to understand, when we try to formulate people's behavior, normal or abnormal, we could think about it not only as what biopsychosocial factors are impacting the behavior, but what of those factors, which ones predispose, precipitate, and perpetuate. What precipitates this? What's the reason why it starts? Because those reasons can be, and often are, very different than those that perpetuate it. Why would somebody actually not correct her coworker in this case?
She's scared of confrontation.
More to it, go ahead.
Her supervisor said something about like how Elaine, her own self, was like she portrayed her in a negative manner, and so she didn't want to be associated with those images.
Right? I mean, it comes with self-image, and then in getting information from her coworker, it's almost like she's in a position of power. You could hear what people are talking or thinking about you if you don't know that it's you. And I think that's what really what is guiding this in the beginning. Now, what perpetuate, I think, becomes different in terms of her, like you said, just continuing to have to live this lie and not be exposed. Those are different factors. So I think outside of the content about what specifically might be the precipitant versus the perpetuating factor is the general idea that we have to continue to think of human behavior through not only biopsychosocial elements and factors, but I think just as importantly, things that predispose, precipitate, and perpetuate. I mean, that's really something that in psychiatry training we are very, very focused on, especially in office-based practice, right? Well, inpatient psychiatry too. All right? Final thoughts.
I haven't watched the whole show, but did Jerry and Elaine like have a relationship before?
Yeah.
Yeah, they had a sentence, but isn't that unhealthy that there's still like this? Because I haven't watched it, so I don't really know anything about it.
Yeah. Any thoughts? I mean, clearly Larry David built that for comedy purposes, right? But there's really almost zero translation in real life human behavior / office-based practice. All right, we'll leave it there.